Just a minute.
Anjali, don't share as yet. We have to
Yes,
begin.
ma'am.
आपण recording start केलंय ना?
हाँ.
Yeah.
Okay, ma'am.
Good evening, everyone, and welcome to our monthly CME. This is one of our many monthly CMEs webinar we have started. We started in the year 2021 during COVID times, and this has proved to be a boon for all of us because there's great learning that goes on these webinars. We generally meet on the fourth Wednesday of every month, and we have very interesting case presentations. And today we have two such very interesting, one by a very junior a pediatrician who has just completed her MD Pediatrics, and another one by one of our invitees from Borivali. And I'm very happy to say that we have these very interesting cases. We have invited two of our experts. In fact, we invited three. One is Dr. Amit Vatkar, pediatric neurologist who practices at Virar, Vasai, and also in South Bombay. We also invited Dr. Amit Jain, who's a pediatric hemato-oncologist who practices at Borivali Pediatric Comprehensive Thalassemia Care Center. He also helps us conduct our anemia OPD, sickle cell OPD at Dahanu. We invited Dr. Kishore Chauhan, who is our WHO consultant for Vasai Virar area VVCMC. All three experts are extremely busy today. Dr. Amit Vatkar promised to join in a while. Dr. Amit Jain is very busy in a meeting. Dr. Kishore Chauhan is in a very busy meeting of the WHO. I really hope that by the time we come to presentations of their related topics, they can join. First of all, I'd like to wish all of you a very happy new year. This is our first CME in the new year, and a very happy learning, practicing pediatrics in 2023. And we flag off our CME in this year with this CME today. I want to welcome Dr. Hemant Joshi and Dr. Archana Joshi. They have become grandparents for the second time, and I always look forward to Dr. Hemant Joshi's comments, Dr. Archana Joshi's comments, and I hope they do join in and comment on our cases as well as our epidemiology. I want to inform you all that since May of last year, 2022, we have started anemia OPD at Dahanu, where there is a very huge sickle belt. And we had one such OPD on the 21st of January. I'm happy to say that we had 120 children who came that day, of which 40 were our regular patients who have registered with us before, and there were 80 new children who were diagnosed as thalassemia trait in a school checkup. The incidence of sickle cell in this sickle belt of Maharashtra is 40%. That's a very huge number. And Dr. Amit Jain informed us that of the 80 children who had come from school, all were thalassemia trait, except one who was was sickle trait, except one girl who was a sickle cell disease, who was anyway following up with us. So there is a large population that needs care, counseling, treatment, management, and IAP Palghar, along with the Hanu Sub-District Hospital, with CTC, ICMR, and the Rashtriya Balak Seva RSBK is also conjointly doing this anemia OPD. We've had about 6 or 7 such OPDs, but we are planning to have one every month. This was the update about our sickle cell OPD at the Hanu. And we have also started this program of immunizing these children with typhoid vaccine. Happy to inform you that on the 28th of January, IIP Palghar, along with cochlear group, which does free cochlear transplants, is conducting a free OAE as well as BERA camp at Vasai. And this is going to be available to anyone who wants to do this. There will be free counseling as well. And anyone who deserves a cochlear transplant will be counseled and guided to where it can be done. It will be done totally free of cost. I will be sharing that poster in a while, and anyone who wants to avail of this can please do so. So this month we have this. We are also planning to conduct our National Girl Child Day later in this month, and the details of that will be shared. Today, I welcome Dr. Archana Joshi, our ex-president and team leader of our IIP Palghar. I welcome Dr. Anuradha Palvankar, our treasurer, Dr. Vaibhavi Barot, our secretary. I request Archana Joshi to say a few words and share her experiences of her stay in London, so that we get some insight into how pediatrics or newborn care is practiced there, if it's any different.
Hello, good evening, everyone. Wishing you all a very happy new year.
Thank you.
And a very happy Sankrant. So it is said in Marathi, Til Gud Ghya and Gol Gol Bola. So today we always talk sweet, Palghar Academy of Pediatrics, politeness and sweet talk. So we already do that, so we'll do so more. And I would also like to congratulate our president and all the office bearers that we have been selected as the best branch from the Central IAP, and we have got about 8 prizes this time. So our branch needs a big round of applause for that. And I was, for last 1.5 months, I was in UK with my daughter who delivered a baby girl. But they follow all protocols and they don't hurry up the things. My daughter was in labor right for about 100 hours. And we could not see her bearing all that pain, and we're just wondering, had it been India, we could have got her cesarean done, or we could have got her relieved and all, but they would all go according to the protocol. Her father-in-law was a consultant there in the same hospital. His colleagues would come and see the girl, but they said everything is okay. They would just reassure us, but they followed the full protocol, and she was in labor from 4 a.m. on Monday. 4 a.m. she was in pain, and finally on Friday morning, so the 5th day, Friday morning, she had a meconium stained liquor, so they took her for cesarean then. And they also waited for her to give epidural till she was 4 centimeter dilated. She had gone 6 centimeter dilatation in these 100 hours, but they didn't give her Pitocin or anything to expedite the delivery. So this was the state of affairs, and I'm so happy that we are in India and decisions are taken quick and they don't stick to the protocol. They follow the thing. So I'm very happy that I belong to India. And even they keep weighing the baby every 4th day, and if there's even 35 grams of more weight loss, the baby is taken again back. And they did 4 pricks for my grandchild. They did 1 for sugar. Somebody came and said, no sugar, so they did HGT. Then somebody said, now the baby is lost 35 grams of weight, so we need to do sodium. So they did sodium, 2nd prick, again 3rd prick for something, and 4th prick for something, and they made our baby cry and cry and cry. So I was just not happy with the system. And I'm happy that, and I also pray to all of you that please combine everything. If you want to do bilirubin, you want to do sugar, just give the baby 1 prick and treat every child as your own child or grandchild. So these mishaps will not happen. So I'm very happy that India follows great rules and has brains to decide what is to be done when, which was lacking in UK. Even we had doctors from India or Pakistan, but they had to stick to their protocols. So I'm happy, and I'm happy to share my experience with you all, and wish you all the best. Thank you, Anjali. Thank you for giving me an opportunity to talk.
Thank you so much, Archana, for sharing that, because I think here people practice intuitively and do right by the child and not necessarily by the protocols. So protocols are just guidelines, and we don't have to go very strictly by it. We have to follow our intuition and know when things are going wrong. So thank you for sharing that experience that reiterates our faith in ourselves and our system. Thank you so much. Is Hemant around, and would you like to say something about Sankranti and Tilgul?
Hemant?
Yeah.
Dr. Hemant Joshi, we'd love to hear about Tilgul and about Sankranti festival and kite fly.
अंजली सारखं बोललं की गोड अलग बोलायची गरज नाही. We are all fans and followers of Anjali and Suhas. नंबर 1. नंबर 2, हे खूप इम्पॉर्टंट आहे तिळगुळचा फेस्टिवल, कारण एक तीळ 7 लोकांनी वाटून खाल्ला पाहिजे, म्हणजे शेअर. वेन यू रिसीव्ह समथिंग यू फील हॅपी 1 युनिट. तुम्हाला काय मिळालं की 1 युनिट आनंद होतो, पण तुम्ही देता तेव्हा 100 युनिट आनंद होतो. हे दिल्यावर कळेल. सो मम्मी जेव्हा बाळाला दूध पाजून वाढवते ना, तो जो आनंद आहे ना, तो कोणा माणसाला मिळू शकत नाही. तिचा जो देण्याचा आनंद आहे. हे झालं नंबर 1. नंबर 2, सगळ्यात महत्वाचं, संक्रांतीला 2-4 गोष्टी सांगत आहे. संक्रांतीला मुलांचं बोरन्हाण करतात. म्हणजे काय करतात की मुलांना एवढे फ्रुट्स खायला देतात की त्यांनी त्याला आंघोळ करता आली पाहिजे. म्हणजे प्लेंटी ऑफ फ्रुट्स इन द हाऊस हा कन्सेप्ट आहे. सो मेक युअर बिकम फ्रुटेरियन्स. सफळ जगा. एवढे फळं घरात ठेवा की मुलांना त्यांनी आंघोळ करता आली पाहिजे. इकडे फळं तिकडे फळं, सगळीकडे फळच फळं. आणि रिप्लेस गोळी आणि चॉकलेट बाय फ्रुट्स. गोळी चॉकलेटची शुगर दाताला चिटकते, तिथे केरीज होते, फर्मेंटेशन होते शुगरचं बॅक्टेरियामुळे, तिथे ड्रिलिंग होते. कॅल्शियम इज डिस्ट्रॉयड बाय द ऍसिड क्रिएटेड बाय द बॅक्टेरिया फ्रॉम द शुगर. सो नो शुगर इन द हाऊस, नो गोळी चॉकलेट, नो केरीज टीथ, बिकॉज 95% इंडियन्स आर केरीज टीथ, ऑल डॉक्टर्स इन्क्लुडेड. सो सेव्ह आवर न्यू बेबीज, नंबर 1. नंबर 2, फ्रुट्स आर व्हेरी चीप. 40 रुपये, 50 रुपये, 100 रुपये किलो. आणि आमचं ब्रेड, बिस्किट, केक इज 1000 रुपये किलो, 500 रुपये किलो. चॉकलेट्स आर 500 रुपीज किलो. म्हणजे एनिथिंग अबव्ह 100. सो 1, बी नॅचरल, आणि दे गिव्ह मिनरल्स, विटॅमिन्स, फायबर्स, अँटीऑक्सिडंट्स, एव्हरीथिंग. तर बी फ्रुटेरियन्स. आपला प्रत्येक अर्धा घास फळाचा पाहिजे. हे मुलांना शिकवायसाठी तुम्ही त्यांना बोरांनी आंघोळ घाला. आणि शबरीसनी बोर खाऊन रामाला दिलं तसं तुम्ही चव घेतल्याशिवाय बाळाला देऊ नका. मेडिसिन किंवा फूड चव घेतल्याशिवाय देऊ नका. आणि त्यात आईचं दूध टाकून द्या. आईचं दूध टाकून दिलं की ते जास्त टेस्टी होतं आणि मुलं जास्त चांगलं घेतात, अशा स्टडीज आहेत. ठीक आहे. नंतर आता तुम्हाला शॉकिंग सांगतो, NFHS 5 नॅशनल फॅमिली हेल्थ सर्वे 5 चा 2020चा महाराष्ट्राचा अभ्यास आहे. माझ्याकडे 2 MSc स्टॅटिस्टिक्स माणसं सर्वेला आले होते. म्हणजे हा सर्वे फालतू लोकांनी केलेला नाहीये. तो सांगतोय की 10 पैकी 9 मराठी मुलं सेकंड बर्थडेला मालनरिज्ड आहेत. 9 out of 10 children are malnourished at second birthday. This is because we give mother's milk, but we fail to give home solid food. We give them milk, rice water, dal water, and starve them from the day mother's milk is not enough. So start with home solid food, number 1. Number 2, National Nutrition Monitoring Bureau, NNMB, and NIN, National Institute of Nutrition, they have head office at the same center. त्यांचा अभ्यास असा आहे की लेसन नंबर 1, 10 पैकी 9 मुलं मालनरिज्ड आहेत, इंडियन मुलं महाराष्ट्रातले. लेसन नंबर 2, इन malnourished children there is a 90% deficit of fat in their food. So energy deficient is 25%, protein deficit is 25%, but fat deficit is 90%. कारण लहान बिलो 2 इयर्सच्या मुलांना तेल तूप मिळत नाही. सो तिळ खाल्ला तर तेल मिळणार, खोबरं खाल्लं तेल मिळणार, जवस खाल्लं तर मेंदू वाढायला जे लागतं ना ओमेगा 3 फॅटी ऍसिड्स ते मिळणार. तर प्रत्येकाने पर हेड 10 ग्राम जवस खाल्लं पाहिजे किंवा 3 ग्राम जवसचं ऑइल खाल्लं पाहिजे. पूर्वी महाराष्ट्रामध्ये जवसाचं तेलच स्टँडर्ड ऑइल होतं. आपण सगळे बदलून गेलो. किंवा मग 1 पार्ट सोयाबीन ऑइल आणि 1 पार्ट शेंगदाण्याचं ऑइल याच्या मिक्सरने मुलांना पूर्ण ओमेगा 3 जे DHS तुम्ही हजारो रुपये किलो प्रिस्क्राईब करतात ते करू नका.
हेमंत, व्हॉट इज जवस तेल?
जवस इज फ्लॅक्सीड, आळशी. सो आळस सोडा, आळशीचं बी खा, आळशीचं तेल खा आणि 1 स्पून इज इनफ पर हेड. 3 grams इज इनफ, किंवा 10 ग्राम. अळशी चटणी खूप छान होते, मी तुम्हाला खाऊ घाल आमच्याकडे नेक्स्ट तुम्ही याल. कीप वन नेक्स्ट फिजिकल मीटिंग विथ अस, विल होस्ट युअर लंच अँड विल गिव्ह यू दॅट. आणि तिळगुळाचं महत्व काय माहितीये का? आता सगळ्यात महत्वाचं सांगत आहे की एक दणकट माणूस आहे, मी स्ट्रॉंग बॉडी बिल्डर, माझी एक करंगळी अवशी आहे आणि मी दुसरा बारीक माणूस आहे, त्यांनी अशी हात फिस्ट केली आणि मारला ना तर ती त्याची करंगळी मोडणार. आम्ही सगळे जगाशी कट्टी हुशार पिडियाट्रिशियन, अशी करंगळी सारखे, आणि फालतू लोक आम्हाला पण आम्ही असे झाला ना तर 5 बोट पण मोडू शकत नाही. सो एकत्र आलं पाहिजे, वन्स अ वीक, वन्स अ मंथ, मेक 1 पिकनिक एव्हरी मंथ, आणि मग तुम्हाला आपल्याला कोणी हात लावू शकणार नाही. आणि हे संक्रांतीला तिळगुळ वाटून शिकतात, म्हणून संक्रांत केली पाहिजे. शेवटचं सांगतो संपवतो. आपल्याला खूप स्ट्रेसफुल लाईफ आहे सगळ्यांना, म्हणून सगळे सण केले पाहिजे, त्यात आनंद आहे. सो सेलिब्रेट, बी हॅपी अँड शेअर हॅपीनेस. थँक्यू.
थँक्यू सो मच डॉक्टर हेमंत जोशी. आणि आपण सगळ्यांनी शॉर्ट्स घालून पतंग उडवले पाहिजेत, म्हणजे भरपूर व्हिटॅमिन डी आपल्याला डॉक्टर हेमंत जोशी नेहमी सांगत असतात, त्याप्रमाणे केलं पाहिजे. अँड थँक्यू फॉर ऑल द इन्साइट्स यू शेअर्ड अबाउट तीळ, गुळ, जवस. अँड एकजूट होऊन आपण सामना केला पाहिजे अबाउट लाडू. So we'll do that, and with that I think we can go on to our
एक
first
सेकंड अजून
phase.
सांगतो.
बोला ना.
सगळे पिडियाट्रिशियन 100 किलो लाडू आणा. आजपासून 1 महिना सगळ्यांना 1 लाडू द्या, रिक्षावाल्याला द्या, शेजाऱ्याला द्या, पूर्ण परिसरात सगळे मित्र झाले पाहिजे. म्हणजे तुम्ही रस्त्यावर उद्या पडले ना तर नाहीतर कोणी विचारायला येणार नाही. कलियुग आहे, सगळ्यांना मदत लागते. सो 100 किलो लाडू आणा, सगळ्या रिक्षावाल्यांना द्या, फ्रेंडना द्या, शेजाऱ्याला द्या, भांड्याला लोक उरले पाहिजे त्यांना पण द्या, म्हणजे ते गोड भांडतील. थँक्यू.
What a lovely thought. You have left us with a lovely thought, and I think this is particularly important because yesterday, काल मी माझ्या मैत्रिणीच्या मुलीला भेटायला गेलेली. शी इज प्रेग्नंट, शी इज ड्यू इन मे, and she was eating chai and biscuits as if that was a very good meal. And I was so surprised. I said, संक्रांतीच्या काळात तू बिस्किट काय खाते? So that's why I think this it's very important. Dr. Hemant Joshi keeps stressing that eating natural, eating fruits, eating tilgur, the importance of that. And I remembered you, Hemant, and thank you for all that you shared.
आणि एक न विचारलेलं सांगतो. मॅसेटर्स आर द स्ट्रॉंगेस्ट मसल्स ऑफ द बॉडी. दिस टू दे आर स्ट्रॉंगर दॅन द क्वाड्रिसेप्स. पायाच्या मसल्स पेक्षा पण हे स्ट्रॉंग आहेत, पण आपण कुक्ड फूड खाऊन त्यांना वीक करून टाकलेलं आहे. आपण ऊस तोडू शकत नाही, आपण अक्रोड तोडू शकत नाही. मुलीला कोणी त्रास द्यायला लागला ना तर त्यांनी एवढ्या जोराने चावलं पाहिजे की त्याचं मसल तुटलं पाहिजे. हे शिकण्यासाठी कच्चे तीळ खा, कच्चे बोरं खा, कच्चे अक्रोड, सगळं कडक कडक खा. कुणाची हिंमत नाही झाली पाहिजे जवळ आले की जी मसलचा तुकडा चावते ना तिला कोण हात लावणार नाही. इट्स पॉसिबल, लर्न इट.
Yes.
थँक्यू.
Thank you so much. And with that, we go to a very young pediatrician. Our senior most pediatrician today here is Dr. Hemant Joshi, and the youngest pediatrician here is standing behind him. आणि मी तुझ्या पाठीशी आहे असं म्हणते आहे ती. आणि शी इज डॉक्टर अंजली मुजुमदार. डॉक्टर या.
आणि शी लॉस्ट 8 kilos in 8 weeks.
Superb. Superb. So Dr. Anjali Muzumdar is our youngest pediatrician. She's done her MD from Loni, Pravra, and today she's going to present a case of Bell's palsy. So can I request I had invited Dr. Vatkar, Amit Vatkar. I shall give him a call. Anuradha, can you call Dr. Amit Vatkar and ask him to join, please? Yeah. Anjali, you can start.
Okay. Thank you, sir. Okay. Yes, sir. Uh, Good afternoon. I am Dr. Anjali Muzumdar. I will be presenting a interesting case of facial nerve palsy. So this patient was admitted with us in Joshi Children's Hospital on 19th November 2022 and was here for 3 days. He was a 4-year, 6-month-old male child, resident of Fulpada in Virar East. The informant is mother and she was reliable. The chief complaints was high-grade fever since 3 or 4 days and deviation of face to the left side since 1 day. History of present illness. The child, the fever was acute in onset. There were high-grade fever spikes since the first day. They were remittent, not associated with chills or rigor. Child was active during the interfebrile period and oral intake was good. Deviation of face to left was noticed 1 day before the admission. It was acute in onset, noted when the child woke from the afternoon nap. It was associated with inability to close the right eye, watering from the eye, and drooling from the right angle of mouth. Patient was taking treatment from a general practitioner and was on syrup, cefpodoxime, montelukast, levocetirizine, ibuprofen, paracetamol, and ondansetron for a period of 2 days. Negative history. Here to note is there was no recent complaints of cough or cold. Besides that, to rule out other cranial nerve involvements, I asked there was no history of blurring of vision or diplopia or change in voice. There was no generalized involvement of any limbs like weakness of limbs or difficulty in walking. And there is no history suggestive of altered sensations. So sensory involvement of other parts of the body was not there. There was no history of imbalance, giddiness, vomiting, or headache. And this I asked to rule out the pathway of the seventh nerve, since it passes through the temporal bone. So this is the negative history to rule out that. There is no history suggestive of ear vesicles, ear pain, ear discharge, or reduced hearing. This could point to a local cause which can result from trauma or inflammation. So it was not suggestive of that. There was no history of recent trauma or swelling over the face. So there was no compression or swelling of the parotids or any sort of that stuff which could cause these symptoms. Then in the past history, there were no similar episodes or hospitalizations in the past. And there is no history of seizure disorder in the patient or the family. There is no history of tuberculosis in the patient or the family. The birth history was reasonably normal. The patient consumed a mixed diet. I will move to the examination now. This was the patient at admission. As you can see, there is weakness of the right side of the face. There was inability to close the right eye. And there was the deviation of angle of mouth towards the left on admission. On examination, the child is alert, active, responsive, is Fahrenheit. The child's vitals were stable. Mild pallor was present. There was no edema or lymphadenopathy. On face, ear, and throat examination, it was nothing abnormal was detected. There was no inflammation, no discharge, no vesicles which were seen. Deviation of angle of mouth was towards the left, and loss of the nasolabial folds towards the right side of the face were seen. Failure to close the right eye was seen, and there were loss of creases on the right side of the forehead. On cranial nerves, on CNS examination, the higher mental functions were preserved. Intelligence and memory were normal. speech dysarthria was present involving the labral syllables, otherwise the speech was normal. Sorry?
No, go ahead.
Okay. On cranial nerves, the first nerve was normal.
Pallavi, please mute everyone. Only speakers to unmute.
Yes, ma'am. Yes, ma'am.
Higher mental functions, the cranial nerve, the cranial nerve's first nerve was normal bilaterally. Its second nerve, visual acuity and finger counting to 5 meters were present bilaterally. Normal third, fourth, and sixth nerve, the mobility of the eye was checked. They were normal in all the directions. Pupils were bilaterally reactive to light equally, both with direct and consensual light reflex. In the fifth nerve, the sensory and motor components were tested, and they were intact bilaterally. For the seventh nerve on the right side, as you can see in this picture, there was loss of nasolabial folds, loss of wrinkling, inability to raise the right eyebrow, buccinator weakness of the right side, which was manifested as not being able to puff the mouth, drooling of saliva, and difficulty chewing on that side. Bell's phenomenon was present. So Bell's phenomenon is when the child closes the eyes. There is naturally upward movement of the eyelids. So it is a kind of a protective mechanism. So this could be elicited in this patient. The taste sensation was normal. To the left side was normal except the deviation of angle of mouth to the left. Then the state nerve examination, the child could hear equally on both sides, so it was normal. 9th and 10th palatal movements were present and equal bilaterally. So we also graded the facial nerve weakness. So for facial nerve palsy, this is the House-Brackman staging which is used. Grade 1 suggests a normal power. Grade 2 suggests mild palsy, no deviation, and complete closure. Grade 3 is moderate, closes eye with maximal effort and mild asymmetry. Grade 4 is moderately severe, between 2 and 5. Grade 5 was severe, no closure of eyes and complete deviation. And grade 6 is complete paralysis. So our patient was grade 5 of this House-Brackman scale. Motor system the examination was normal. Tone, power, and reflexes were equal bilaterally. Pain, touch, temperature, sensations were normal. Fine touch bilateral. So anterior, posterior column sensations were preserved. Cerebellar signs, no cerebellar signs were elicited. No signs of meningeal irritation were present. Gait was normal. Skull, spines, carotids, or auscultation all were normal. And rest of the systemic examination was normal. So to summarize the case, this was a 6-month-old male child with isolated facial paralysis of the right side of the lower motor neuron type with a prior history suggestive of viral infection, grade 5, probably Bell's palsy lower motor neuron type, or it also could be secondary to viral infection. So the diagnosis is idiopathic and secondary to viral infection. So investigations which were done at admission, HB was slightly low, 9.5, and the CRP was raised up to 68. Typhi IgM, which was done outside, was negative. We gave a course of injectable ampicillin to the patient, and under that we started steroids for 15 days. In Nelson, the management, the prognosis of Bell's palsy is quite good, and usually does not require antivirals for children. Even if it is of viral etiology, antivirals are generally required for adults. So for children, steroids, this we got from a paper. So we started steroids at 1.75 mkd, and we tapered it very slowly, 2.5 mkd before stopping over the course of 15 days. So the improvement was very remarkable in this child. This we got it on his follow-up, 1 month follow-up for this child. As you can see, it is mostly resolved, except for the little bit of deviation to the left side. The right side was remarkably normal. He was able to close the eyes completely. Even during the 3 days of hospital stay, he was able to close the right eye. So the improvement is very quick and very remarkable in children for Bell's palsy, and the prognosis is very good. So this was a very interesting case that we got.
Excellent, excellent. And Dr. Amit Vatkar is online. And Dr. Amit Vatkar, we'd like your comments on Bell's palsy and lower motor neuron type of facial palsy, please.
So the majority of the cases which present with facial nerve palsy, we most of the time find out that it is either para or post-infectious. So maybe there is some viral fever, cough and cold, either just 2 to 3 days back or 15 days back. It can present either way. Most of the time they present with almost complete facial paralysis, that is case 5. The major differentiating factor we have to see that whether they are able to frown. So if they are able to frown, that means they are able to raise their both the eyebrows on the upper side. That means it's an upper motor neuron. But most of the time it is lower motor neuron, because for it to be upper motor neuron, you need to have something compressing your brainstem or some where there is the origin of the nerve. Okay, so that's very rare. So most of the time it is LMN, but you should always look for frowning. In which case that may not be that will clearly prove whether it is lower motor neuron or not. In some cases, you need to differentiate exactly where the block is there. Most of the time, like in case of tuberculosis or in case of parotitis, because the taste may be affected, the hearing sensation may be affected. In smaller children, it is usually not possible to do all those things. Yes, but taste is sometimes we can appreciate, but then it has to be done very meticulously by catching the tongue and then putting either sweet or salty solution on the either side, and we have to see which side of the taste is affected or not. That helps in localizing where the nerve would have been probably blocked. So as I said, it is usually post-infectious, so steroids act like an immunomodulator and they are helpful in almost 90% of the cases. In cases where there is recurrent Bell's nerve palsy, in these cases, we should always suspect herpes. And in these cases, antivirals like acyclovir may be indicated when there is a recurrent facial nerve palsy. Facial palsy maximum, they can show recoverment in the first 1 month and 3 months. So 3 months, what we take to show almost 95% of recovery in 3 months. So most of the cases recover by 3 months. So we have to continue on physiotherapy, and sometimes physiotherapists give some vibration sense which helps in faster recovery of the facial nerve palsy.
Do we have to do a CT scan of the brain to rule out a CNS?
When it is obvious lower motor neuron palsy, first time presentation, no need to do any CT scan or any other investigations are not warranted. But if it is a recurrent case of facial nerve palsy, if it is a non-improving, that means despite of 3 months, there is no improvement. In such cases, you will have to investigate further and see what's causing the nerve to be blocked for so long, or recurrent, what's causing the nerve to get paralyzed. These are the 2 indications where you have to do further investigate. Either it can be in form of neuroimaging, and sometimes you need to do a EMG, NCV to see that whether there is regeneration in the nerve or no regeneration in the nerve.
Dr. Amit, how many children have you seen who have not recovered from their palsy?
3. I have seen 3 cases who did not recover, one of them had herpes, but then afterwards, starting anticyclovir, they recovered. One of them was an old case of means one of them had developed a tuberculoma, which has caused the block, and then that subsequently after treating tuberculoma, it recovered somewhat. And the other
So,
case,
Dr. Amit, sorry to interrupt, but there was a tuberculoma.
brainstem. So
I
that
see.
lower basal cistern, so there was there, and I suspected some adhesions could have been further complicating the picture. So I gave steroids for a pretty long enough time, and then gradually later on they showed some improvement.
So that child with tuberculoma had the signs of raised ICT, and that's how you suspected it? How did
No,
you
no, no,
suspect?
no, no, no. He was an old case who had taken some medication, and then now the child presented freshly with these new symptoms. So it was just a new crop of tuberculoma. But then anyway, I started all AKT and everything for that guy, kid. But since he was an old case, so I further investigated it.
Old case of facial palsy with a tuberculoma.
Tuberculoma.
Old case of
He was a
tuberculoma with
TB. Old case of CNS TB presented with facial palsy. I treated like usual, but since it was not responding, so then I re-imaged him, and there was a new tuberculoma.
So one case was herpes zoster, one case was
Tuberculoma.
and the third
And the
case
third
was
one, I don't remember now exactly. I did not find any cause, I suppose, in the third one. Maybe one was that which I eventually I said that maybe he will improve. He was a case of recurrent 2 to 3 times he had.
so from the hundreds of patients you see of lower motor neuron palsy, you have seen 3 which have not recovered.
All of them recover except few exceptional cases which it may require somewhat more intervention. Otherwise, all of them recover. Some may take some time, like a month. Some may take up to 3 months, but most of them recover.
And no, unlike adults, we don't have to give antiviral like acyclovir.
Only in case of recurrent one, where you suspect herpes, you have to give antiviral. Otherwise, no need.
And also, Dr. Amit, we always inform the WHO consultant for polio.
Yeah, because polio is one of the virus that can cause facial nerve palsy. So facial nerve palsy is included in this AFP reporting. To AFP reporting, basic purpose is to increase the sensitivity. You look for more and more viruses in the hope to find out that there is no polio virus. So reporting is to find no polio virus surely. So you have to double stress it. So for that, wherever it is possible to get a virus that causes nerve inflammation, you have to try and find which virus it is. So it's by exclusion. The more the thing you have to exclude, the better it is. So for that purpose, Bell's palsy is included under AFP reporting.
AFP. So it's under surveillance just to rule
Yes.
out polio, because we are trying to eliminate polio.
Definitely.
Also wanted to ask, how often is it a part of post-vaccination adverse reactions like an
I did
ADAM or
not
something?
see. No,
You haven't
no.
seen.
I
So
did not find it as a post-vaccination.
So vaccination definitely does not cause. So infectious,
never
para-infectious, and very rarely you can find herpes zoster or any of the other symptoms.
Definitely.
Yeah.
At least in children.
Yeah. Any other questions? Anuradha or Dr. Archana, Donilda, anyone who is there? Sanjay?
We have Dr. Alka, we have Anjali, we have Dr. Alka Jadhav online.
Dr. Alka, welcome. And she's mentor for Dr. Anjali Muzumdar. And I would request Dr. Alka to say a few words especially on pediatric Bell's palsy.
Alka is
You're muted.
Professor of IIP Palghar.
IIP, Alka, you are on mute.
Alka, you are emeritus professor of advisor of IIP Palghar.
Absolutely.
No. Only point I want to make is it is a notice. Palsy is the only ENT condition where we report it for AFP surveillance.
Yes. Dr.
Up to the age of 14 years, because it's an element palsy.
Yeah.
Okay. So we should be reporting this case to epidemiology cell.
I think it's already been done.
I don't know how do you report it to the epidemiology cell in Virar, whether you all have ideas, otherwise you can explain them. Because BMC I know, But
We are
how
digital.
about Pasai Virar Nala Sopara?
Sir, madam, we have a
We are
WhatsApp group.
digital.
AFP surveillance group has been made, and our full means Palghar district reports in that group. So it,
Okay.
the WHO and all are, our report directly goes to the WHO, which our Palghar MO, and then they come, and then if it is a, if the report is as AFB, they come, they collect the stool samples, and in recently in the outbreak in measles, they had come and collected the throat swabs and the serum samples also. So this we are connected with the MO and everything.
Good,
Dr.
very
Kishore,
good. So the
yeah.
network continues.
Yes.
Dr. Kishore Sawan, WHO consultant for VGCMC, has been very active and very prompt in collecting samples and taking note of our infectious diseases. And we report AFP, we report measles, we report any fever with rash, and we also report diphtheria, tetanus, pertussis, and all vaccine preventable illnesses. Dr. Anjali wants to say something. Yeah.
Yeah.
Sir, I had a question for Amit Vatkar, sir. Sir, how long can we wait for the remission of symptoms before deciding whether to investigate further or
3 months, 3 months. So as I mentioned, 95% of cases in first 3 months give the result. And if it is LMN, 3 months is the best thing. In 3 months, almost every one of them recover. And you have seen some improvement in the first month. Means it cannot be that there is no improvement for 2 months and suddenly last month it starts improving. It doesn't happen that way. Some improvement in the first month is always seen. So sometimes what I do, I increase the course of steroids. Now you have given it over 15 days, but I give full dose for 15 days and then I gradually reduce it. If after 15 days when I call for follow-up, if I see that everything is fine, then I reduce it fastly. Otherwise, then I reduce it at a very slower rate.
Well said.
Thank you so much. So yeah, so your normal protocol is to give for 15 days full course.
Yes, that's what I do. I usually give for 15 days because 7 days means I did not find much benefit in most of my cases within first 7 days. So I usually give it for 15 days and then I gradually taper it over the next 15 days depending on how the patient has responded.
Thank you so much. Dr. Amit Vatkar is available for consultation, pediatric neurology consultation at Vasai and Virar every Thursday. And he has been of great help to us for all our neurology cases. Thank you so much, Dr. Amit Vatkar, for making it today. And hoping to hear more from you. And if there is any, thank you, Alka, for joining in as well. And I request Dr. Alka to please stay with us because we have many more interesting cases. And thank you, Anjali, for presenting this and opening. Yeah, Dr. Hemant.
आता आपल्याकडे अल कायदा आहे.
Yeah, Al-Qaeda. So Alka, thank you so much. And with that, we go to our second case. And presenting this is our guest speaker for today, Dr. Dimple Jain. And Dr. Dimple Jain, can you please put on your video? And I'm not sure.
Actually, I thought.
No, your video is not on. I can't see you.
Okay. I'll just change the settings. Video from my side is on, but even I can't see myself. Why? I don't know. Ma'am, it's on actually. I am also.
Ma'am, maybe your webcam is not working. Are you joining from PC?
Yes, I am.
Okay.
It was working earlier. Okay, I don't know.
Just try to share your presentation if we can
I
see.
will. Yeah.
I'd like to introduce Dr. Dimple Jain. She's a very distinguished guest. She's a consultant pediatric gastroenterologist, hepatologist, and a liver transplant physician. She's affiliated as a consultant to the Jupiter Hospital, Thane, a very, very prestigious hospital. She has trained from PDCC, SGPGI, Lucknow. She has done her clinical observership in pediatric hepatology and liver transplantation at King's College Hospital, London. A warm welcome to Dr. Dimple Jain, and can I request you to go on with your presentation and your case?
Thank you very much, Anjali ma'am, for giving me this opportunity.
Ma'am, you are visible now. Just share your presentation.
I don't know, is this a new thing that come up with entire screen, Windows and Chrome tab? What am I supposed to select in this?
Yeah, you have to select your presentation only, ma'am.
Okay.
Is your presentation open with PPT?
No. I'll open it.
Just open the
It's
presentation.
open in another tab actually, not on this tab.
Okay. Just open the presentation first.
Okay.
Make it full screen and then click on the share screen button, ma'am.
Okay, I'll do that. Okay. So my presentation is open in another window.
Okay. Just minimize all the windows and click on the share screen button. You will get the window PPT wherein you have to click.
I am sorry for this confusion.
No, please take your time, Dimple. There is no problem. So, if in the meantime you can send your presentation to Pallavi. Pallavi, can you share your number so that you
Yes,
can
ma'am.
share?
My number is 982271.
I'll have to email it to you, no?
Yeah. I'm just writing my mail ID, ma'am.
Yeah, please. So I'll do that otherwise.
Welcome, Dr. Jagdish Bhadbade. Yeah, seeing you after a long time.
Yeah.
So my only concern is, I'll tell you, there are okay, I'll just close all others probably, and then I'll just.
May text you my email ID in chat box.
I'll do that.
Take your time, Dimple. There's no
And
hurry.
do you want to go ahead with the next presentation till then, if you wish?
The next presentation is mine, and I'm just making some short announcements.
Okay.
The next announcement I'm making is that on the 28th of January at Vasai, we are having a free hearing detection camp for newborns. So anyone who would like to refer a patient for OAE or BERA testing I will be sharing the number, and you can send that to, you can call that number, book your appointment, and these patients will be fully assessed for hearing. Anyone found to have a problem will be counseled, and if required, a free cochlear transplant or implant or even hearing aids will be given. This is on behalf of IIT Palghar. So I will be sending, and we will be participating in this. Also happy to inform you all that along with Wockhardt Hospital, IIT Pediatrics is going to conduct an advanced NRP event for 2 days in the month of February. Details of this will be put up. Dr. Neetu Mundra is coordinating with us for this event. So we have two big events coming up. One is a free hearing detection, as well as a advanced NRP that is going to come up. So please stay tuned, and we'll be sharing details of this very soon. And especially those who have newborns admitted with them and are now 3 months old and have not got their BERA done. Anuradha, you can inform Dr. Nilesh as well, because he's looking after Bolinj and Tulinj hospitals. Dr. Sanjay Waghani, Dr. Jagdish Padpade. If you all have any such patients, we'll be sharing the poster. You can take the contact number and book your registration for this free detection. So that is what I wanted to share. And Vaibhavi, anything else that is coming up?
Anjali,
No, madam, not yet.
Yeah, yes, Archana.
I just wanted everyone to request everyone that they should join us at the International Pediatric Congress, Pedicon. It is very close to us, very close to Virar. Ahmedabad is very close to us. So all of us should go in large numbers, at least on the day when we are getting prizes. So we look a good crowd there. Okay, this is just a request.
Yeah, thank you so much.
The registration fees are very high, so we may not register. We may just come for that function. We will not have lunch or dinners there. Just come for receiving the prize. Okay.
Yes, it's very prestigious in the Mahapedicon in Maharashtra state, in a group of pediatricians with less than 50 members. We had won 8 prizes and we were also considered the best branch. Last year, we had many community projects as well as many other online events.
Yes.
So proud and happy. We have a great team with Anuradha and Vaibhavi. I think I can see myself on this. Okay. Pallavi, we have the presentation.
No, ma'am, I haven't received it. Checking the same.
Okay.
Yeah.
Okay. Till then, can I think of sharing?
Madam, you present your presentation.
Yeah, I'll start presenting. I don't know whether my
Ma'am,
presentation.
received.
Okay, great.
Just
Okay,
received
go
that.
ahead. Yeah, yeah. Please go ahead. Please go ahead.
Okay, so someone is sharing from there, right?
Yeah. Yes.
Yeah. Okay.
Dimple, you
okay,
can
fine.
go ahead. Yeah.
Yeah.
Pallavi,
So good
tell us-
afternoon.
Yeah, Pallavi will tell us when she's ready with the presentation. She'll start presenting. You can start.
Okay. So good afternoon, everyone. I thank Dr. Anjali for giving me this opportunity to present on this forum. And I don't know if Alka madam is still there. So I think from there I started my first exposure of pediatric gastroenterology when I worked as a lecturer with her in Sion Hospital.
Great.
So happy to see you, madam. Yeah. So this is not exactly an interesting case that I'm presenting, but I'm just presenting. Can you make it full screen, please? Hello?
Yeah, ma'am. Is it full
The
screen?
presentation,
No.
can you make it full screen?
Is it full screen now?
No, no. Yeah, it's full screen.
Okay, great. Yeah. So I'm not exactly presenting an interesting case. This is what we see routinely, but there are a few things which can really help us in making a difference in the lives of these babies. And hence, I just wanted to present an approach to neonatal cholestasis. Next slide, please. Yeah. So this is a 56-day-old boy who presented with lethargy, refusal to feed for 4 hours, and seizures, which was 15 minutes back. The child, when presented, was post-ictal. There was pallor. There was mild icterus. The anterior fontanelle was bulging, and pupils were unequal bilaterally. Imaging showed an evidence of an icy bleed. On further investigations, his INR was 4. APTT was just 1.5 times normal. 55 platelets were normal. And his bilirubin was a direct hyperbilirubinemia with a direct bilirubin of 3.8. Next slide, please. So when we inquired further, the mother had noticed slightly high colored urine and her stools were, the baby's stools were always pale. However, which was told to her is normal by the pediatrician as the baby was bottle fed. So this is one mistake that we have still seen. Of course, not by an August crowd, but there are still pale stools being missed. There was a lot of discussion on yellow alert being followed, that how a newborn baby's stools are supposed to be. Even if the baby is bottle fed, if there are persistently pale stools, then they need to be investigated. So this child was stabilized, given FFP, and external ventricular drain insertion was done. And further workup revealed that the child had biliary atresia. And the bleed was due to coagulopathy, which was only because of a secondary vitamin K deficiency. So it was a correctable coagulopathy. Next slide, please. So could this have been prevented? Yes, because it was just a 56-day-old baby. His liver was not totally damaged. It was just because of cholestasis that the baby developed vitamin K deficiency and deranged INR. Next slide. So this was a happy, healthy baby gaining weight adequately. Is that enough? So it should be a routine to ask for during the well baby clinics for the stool color and the urine color of the baby. And it is ideal to show a stool color chart in the clinic, because many times the parents may not be, the first time parents especially may not know what a normal stool color is supposed to be. Next slide, please. So what is cholestasis? As we all know, the stasis of bile, physiologically a decrease in bile flow. I'll skip this. Next slide, please. So how do you define neonatal cholestasis? A prolonged elevation of conjugated bilirubin beyond 14 days of life. If it is more than 20% of the, that is, it is more than 20% if the total serum bilirubin is more than 5. And if the serum bilirubin is less than 5 total, then any direct bilirubin of more than 1 milligram is neonatal cholestasis. It almost, the incidence is almost 1 in 2,500 live births, and almost 30 to 40% of them are a correctable condition, that is biliary atresia. Next slide. This is the second case. This was again a 52-day-old baby who was born of a non-consanguineous marriage, presented with jaundice, which was noticed since 1 month of age, and the baby developed a vaccine site swelling. This is another classical presentation with which these cholestatic babies present. When they go in for their 1.5-month vaccination, they get a vaccine site swelling, and the child had fever for 3 days. Next slide. The birth history was uneventful. The baby was well till 1 month of age, and that's when the parents started noticing progressive jaundice with high colored urine. Next slide. So this is very basic, but just if there are any residents in this. So significance of urine color in jaundice, we all know if the urine is clear like water, we are dealing with the neonatal hyperbilirubinemia, the unconjugated one. If it is a high colored urine, we are looking at a conjugated hyperbilirubinemia, and that is significant. Next slide. So this baby, about this baby, the baby developed swelling over the vaccine site, followed by excessive crying and fever. And for these complaints, the child was hospitalized and found to have coagulopathy, received FFP, IV antibiotics, and then referred for further management. Next slide. So this is a 52-day-old baby with neonatal cholestasis with coagulopathy. How do we proceed further? Next slide. So first and foremost thing, whenever we have a baby with jaundice beyond 14 days of life and the urine is high colored, we know it is a conjugated hyperbilirubinemia. Our first question should be, what is the color of the stool? Is it pale? Is it pigmented? And it's best to have these stool color charts handy, where 1, 2, 3 are the abnormal stools and 4, 5, 6 are the normal stools. And this picture was the color of the baby stool. So we can see it is falling in between. So these are the ambiguous stool colors. And I've just prepared a flow chart of how do we go about in these ambiguous stool colors. Next slide. So what is the importance of stool color in neonatal cholestasis? Persistently pale stool. So we're not talking about just one pale stool and then yellow haldi stools. What we are talking about is if the stools are persistently pale, then it indicates a large bile duct obstruction, that is biliary atresia or a choledochal cyst. In fact, what I would say, what Yacha sir used to always say, it's biliary atresia, biliary atresia, biliary atresia, nothing but biliary atresia. Yeah. Next slide. Second question that we ask is the infant well or it's a sick child? So if the child is accepting feeds well, there's no seizures, no hypoglycemia, there's no failure to thrive, it's a well baby. And if these conditions are there, it's a sick baby. Why do we want to know? Because if it's a sick baby, we are probably looking at a hepatocellular cause. And if it's a well baby, then we are looking at a biliary cause, either extrahepatic or intrahepatic. Next slide. Coagulopathy, we always want to know whether it's a correctable versus uncorrectable coagulopathy. So what do we mean by correctable coagulopathy is after giving 1 dose of IV vitamin K, whether the INR comes back to normal. So if it is correctable, it indicates a biliary disease. If it's uncorrectable, it could be because of metabolic causes or advanced disease. In this case, the child had received FFP 5 days prior, followed by injection vitamin K, and when the baby presented to us, the INR was normal. So it was a correctable coagulopathy. Next slide. So this baby on examination, the weight was 3.9 kg, so weight gain of almost 20 grams per day. There was no dysmorphic features, no cataract. The liver was 3 centimeters soft, a firm liver. Spleen was not palpable, and rest of the systems were normal. Next slide. This was the investigation. There was mild anemia. HB was 10.5 with a direct bilirubin of 5.2. Enzymes were slightly elevated. The next question that we want to know. So once we've confirmed it's a neonatal cholestasis, we've seen that the stools were ambiguous. We've seen that this has been an otherwise well baby, almost 3 grams per day. The next important question that we want to know always, if you ask me, there are only 2 investigations you'll give me in a jaundice baby, then one will be my INR, second will be GGT. We don't need anything else. If we know the urine is high colored and the baby is jaundice, we know it is direct hyperbilirubinemia. The thing that we want to know is the gamma GGT of the patient, because high GGT versus low GGT, our differentials are totally different. Next slide. So here the GGT was 65, which was normal. The ultrasound of the abdomen was done. In USG, what do we want to see? We want to see the size of the gallbladder and the contractility of the gallbladder and a CBD to rule out a choledochal cyst. Since this baby had ambiguous stools, we went ahead with an HIDA in which intestinal activity was seen. I will speak a few lines about HIDA in further slides because I want to clarify this concept of HIDA here. So HIDA has more of a role in ruling out biliary atresia rather than proving biliary atresia. So whenever the stools are ambiguous and we feel that there may be some amount of pigment in the stools, then getting a HIDA is excellent because we are able to see intestinal activity. We can rule out a biliary atresia and we won't need to go ahead with a biopsy. The GALT levels were done, which was normal. Now, even though this is a well baby, it's our protocol to do GALT for these babies. The only reason is easily available test and the treatment is very simple and we can prevent a life-threatening catastrophe for galactosemia. The serum alpha fetoprotein was also 1600, which was normal for age. Here I'd like to make a next slide. So here I'd like to make a point about alpha fetoproteins. So alpha fetoproteins, there are normograms available. So for term babies and for preterm babies, there are normograms. So what is high for adults is not really high for children. In fact, if you see, in the first 2 weeks of life, levels of 50,000 are also normal because it's a liver which is developing. Next slide. And these are the values for preterm babies. Next slide. So this is a little chart that I had prepared. So whenever you see a prolonged jaundice in a baby more than 2 weeks old, first you check for the bilirubin. If it's more than 20% of the total, then it's neonatal cholestasis. You see whether it's a well child or a sick child. You look for the stool color. If the stools are pale, then you know you have to work up for biliary atresia, choledochal cyst. So how do you work up for biliary atresia? First and foremost, you get a 4 hours fasting ultrasound. Now, why 4 hours fasting is in the post-fed state, all gallbladders will be contracted. So if you want to be sure, you want to get a fasting ultrasound, you want to look at the size of the gallbladder. And sometimes there can be something like a ghost gallbladder in biliary atresia, where the gallbladder is big, it's almost 1.8 centimeters, but it is a non-contractile gallbladder. So you not just want to check the size of the gallbladder, but after that, again, you feed the baby and see whether the gallbladder is contracting. You also look for triangular cord sign and you look for the CBD size. So any CBD which is more than 2 millimeters in a neonate is significant, pointing towards a choledochal cyst. And next, as we said, we want to do a GGT. Then depending upon that, we can go ahead with a liver biopsy. Some centers say MRCP, but not really useful. So we do a liver biopsy, or if our suspicion is very, very high, we straight away go on for an intra-op cholangiogram because that is the gold standard for the diagnosis of biliary atresia. So if you see here, if the stools are persistently pale, HIDA comes nowhere in the picture. We have not mentioned HIDA in that normogram. Now, if the stools are pigmented, then you've ruled out biliary atresia. Pigmented means haldi stools, so yellow stools as per the chart. So then the next investigation becomes a gamma GT, where we want to know whether it's low or normal or high gamma GT. So the differentials, of course, they are going on increasing. So when we were training in MBBS, there were only 3 types of PFIC. Now there are 5, 6, 7, and the list is ever expanding. So if it's low or normal, we have 1, 2, 4, 5, and bile acid synthetic defects. If it's high, we are looking at Alagille syndrome PFIC type 3, of which now genetic studies are easily available, so we can go for that. And if the stools are ambiguous, where we do not know about the color, then HIDA can be of help for us. Next slide. So again, if it's a sick child, then these are our differentials for the same infections. So urinary tract infection is a very important cause of presenting as neonatal cholestasis. Then about neonatal viral infection, the CMV, HSV. A word of caution, we've seen a lot of people doing CMV, IgM, and then treating the baby with valganciclovir. So number one, all CMV hepatitis may not be treated. It's very, still there is a lot of discussion going on whether CMV IgM itself is enough to prove that it's CMV hepatitis. If you really want to prove, then it's by CMV PCR. And it's not fair to assume that the cholestasis is because of CMV. And if the stools are pale, you still need to rule out biliary atresia, because we've had children who were thought of as CMV who have later turned out to be biliary atresia. And why the urgency? Because you will miss the bus. If the child is not operated in the first 90 days of life, they are in for a liver transplant. Then you want to look at the metabolic causes. The ones which I have written in red are the ones for which treatment is available. Galactosemia is one disease which is very gratifying to diagnose, because once you diagnose in an early stage, the treatment is very simple. You just have to stop the lactose, switch to soy formula, and the child has to be lifelong lactose free, and they do excellent if diagnosed in time. Tyrosinemia, earlier the treatment was not available and the only option was liver transplant. Now, luckily in India, the treatment is available for tyrosinemia. Nitisinone is available. We still do recommend liver transplant for them, because in the long run, it will be expensive to give them the drug and the special formulas. And then storage disorders like Niemann-Pick type C, HLH can all present. Next slide. And these are just the investigations. You can just keep, So for each disorder, what will be our set of investigation that we like to do? Next slide. Please let me know when I've run out of time. Yeah, ma'am. Already, I think I wasted 5 minutes.
Go ahead, Dimple.
Yeah, and this is just a busy slide. I'm not going to go through this, but just to tell you about the complexity and the more, as genetics is becoming easily available, there are more and more types of disorders which are being diagnosed, which present with neonatal cholestasis. So we have the low GGT, as we said, the PFIC1, the PFIC2, and a lot of TJP2, USP53. We are diagnosing more and more cholestasis. Yeah. Next slide. So this baby, the second one who presented with that hematoma vaccine site, it turned out to be PFIC2. It was compound heterozygous for PFIC2. Next slide. So going back to our discussion, so what do we look for? So first we look whether it was whether the stools were pale pigmented. Then we look whether it was a well child or a sick child. Then we looked at the gamma GT for a diagnosis. Next comes with the pruritus. So pruritus we can detect if the infant is more than 4 months of old. Any child with pruritus, our differentials will be PFIC, Alagille syndrome, especially in Alagille, especially the pruritus is so bad that sometimes that becomes the only indication for liver transplant in them. Alpha-1 antitrypsin deficiency, which we don't see in our part of the country, and a choledochal cyst with cholangitis. It is typically absent in bile acid synthetic defects, because the pruritus is because of the accumulation of bile acids under your skin. So if you have a BSD, you don't have. Why we want to diagnose BSDs in time is now a treatment is available. We have bile acids which we can give. We are still using them off-label, but this is one condition where we can provide treatment. Right? Next slide. Now, next question that we want to know is whether there is an early decompensation. So if you have a neonate who's presented with early decompensation in the form of a coagulopathy or ascites. Coagulopathy means uncorrectable coagulopathy. Then these are the differentials that we need to consider, especially the neonatal hemochromatosis, HSV, HLH, galactosemia. Next slide. Antenatal history. So if there's any history of pruritus in the mother in the antenatal period, we would think of PFIC. We should always look for genital vesicles in HSV. Next slide. And these are just the specific pointers. I don't want to confuse too much, so I'll just skip this slide and I'll go to the biliary atresia one. Next slide. Next slide. Yeah. So biliary atresia, the diagnosis. So what is the utility of investigation? Since this is a commonest 30 to 40% of the neonatal cholestasis, let's go to this. Next slide. So this is a very beautiful chart which is printed in NASPGHAN. So this tells us utility of all the tests. So ultrasound, as we discussed, how we should do the ultrasound and what it can help us with. Ultrasound, the role. So if you don't see a triangular cord sign, it does not rule out biliary atresia. But why we do an ultrasound is to look for other things. Are we looking at a choledochal cyst? Is there polysplenia? Is there asplenia? Are there any portal vein anomalies? GGT, as we said, so in 95% of biliary atresia, your GGT will be high. It's only in 5% that you can have a normal GGT cholestasis, which is biliary atresia. Liver biopsy, almost 98 to 99% sensitive and specific. And also the advantages, it will help us to diagnose other disorders as well. Like if there is a paucity of bile ducts or giant cell transformation. Now, what I want you to see is HIDA scan. So sensitivity is 83 to 100%, meaning if you have a biliary atresia, it will be non-excretory. But look at the specificity. It is as low as 33%. So a non-excretory HIDA does not tell us it is biliary atresia. So I would just put it in what Yacha sir's word is, if you are seeing the stool is white, then your eyes are HIDA. Then you know that it will be a non-excretory HIDA. So let's not waste time over HIDA. Why we are saying that is because you need to prime for HIDA. You can't just do the HIDA scan the same day. You need to 3 days of priming. You need to give Udcament to the baby. Then you do a HIDA. Then they do a 24 hours delayed scan. Then the next day the patient will come back with the report. You wasted an entire week, which is very, very crucial if you are thinking of biliary atresia. So if you're strongly suspecting biliary atresia, no HIDA. HIDA has a role if you feel it is not biliary atresia. Then you do a HIDA, prove that the dye is coming into your intestine and you're sorted. Next slide. Next slide. Yeah. Next slide. I've already mentioned this role of ultrasound, role of MRCP. Next slide. Next slide. So the gold standard, as we said, is an intraop cholangiogram and a histological examination of the duct remnant. Why we still say intraop cholangiogram is, suppose if you pick up a biliary atresia, if you have a pale stools, the child has pale stools in your NICU, the baby is admitted for some other reason. Day 7 itself, you picked up the pale stools. You observe for 3-4 days and the stools are persistently pale. And your GGT is also high. The baby is having direct hyperbilirubinemia. In that situation, better than a liver biopsy also will be to go ahead straight away with an intraop cholangiogram, because that is the gold standard and the biopsy may not pick up changes so early. We still do not have a pathologist who are trained to see the changes of biliary atresia in a babies who are less than 30 days old. So if less than 30 days old, we strongly suspect biliary atresia, we go straight ahead with an intraop cholangiogram. Next slide. So why the hurry? What we've been telling, no, diagnose. So why the hurry is because if a Kasai is performed in less than 60 days of life, then it has a 70% success rate. And after 90 days, it has less than 25% success rate. Next slide. So this is a very beautiful picture. It's a little complex, but I'll take some time here. So on the y-axis, you are seeing the survival of the native liver. And on the x-axis, you are seeing the time after Kasai surgery. And all these graphs are the different ages at which Kasai was done in these children. So if you see the topmost line, the white one, so these were the children in whom Kasai was done at less than 30 days of age. So in neonatal period, if the Kasai was done at 2.5 years after Kasai, almost 80% of the babies have survived with their native liver. And by 15 years post Kasai, 50% of babies are still surviving with their native liver, which is an excellent thing. So we are preventing liver transplant, which is a major thing. And if it is more than 90 days of age that these babies Kasai has been done, then the survival with the native liver is less than 20%. So that is the reason an early Kasai has a role. And as you can see, if there is no Kasai, then almost all the babies will die by 5 years of age without a liver transplant. Next slide. PFIC. So I don't want to go into the details of PFIC. I think what we need to know is we need to be able to be sure that we are not missing biliary atresia. And if it's not biliary atresia and the INR is normal, the child is well, then we have time at hand. Then we can just send a genetics and wait. That is the message that I want to give. Next slide. You can just, yeah, this again, just to tell you the number of PFICs that are coming. Obviously, I'm not going into this slide. Next slide. Yeah. So the key messages I want to give are persistent jaundice beyond 2 weeks of life needs evaluation. Ask the mother about the stool and urine color during a routine visit for timely pickup. Suspect biliary atresia in well-thriving jaundice babies with persistently acolic stools. Very important. Why I'm telling is, even if the baby is not looking jaundiced, ask for stool color. Reason is biliary atresia, the jaundice can be as low as a total bilirubin of 4, which may be very difficult to pick up. And if the baby is sleeping while the babies come to you, it may be missed. So easy question, just the stool color. And the parents may not always know that. Nowadays with the nuclear family, the parents are not even aware of what the stool color they should expect. Prompt decision for surgical intervention for biliary atresia, preferably below 30 days of life, maximum by 100 days is our cutoff. Give IV vitamin K to every cholestatic baby at the first visit. So we've had an incidence where we had a jaundice baby who came to our OPD. We sent them to the ward to get admitted. They went to the ward. They did not get bed. So someone told them to come after the next day. They came after 3-4 days, but with an IC bleed. So we realized that what we need to do is the moment you see a cholestatic baby, you can give 1 dose of IV vitamin K. Of course, you have to be very careful. You have to give it very, very slowly over 10 to 15 minutes because there are rare instances of anaphylaxis to vitamin K. And keep a low index of suspicion for galactosemia. The only reason being it's easily treatable. Next. Thank you. I can't hear you, ma'am. Ma'am, you're on mute.
Yeah. Excellent cases, Dimple, and you brought forth this, the point of looking for cholestatic jaundice early in life. I was reminded of a case I had missed many years ago. I feel very embarrassed, but I do want to share it, especially because you mentioned that a well-thriving child with a bleeding disorder. This child had come for the 6 weeks vaccination, and I had given the vaccination. The child went home and came back the next day only because the bleeding from the injection site wouldn't stop. And at that time, we noticed that this child had mild jaundice. And we had, of course, referred this child to a tertiary care center. At that time, you were not practicing. And that it turned out to be some liver disease. So this point about a well child asking for the stool color is very well taken, because the jaundice was so mild that we had not noticed it on regular. And it was only because this child had a persistent bleed from the vaccination site that biliary atresia was picked up. So your point is very well taken. It is so sad to know that the first child had an IC bleed and
very common, ma'am. It's not just one. Frankly, I'm telling you one, but we've had so many who present to us only with an IC bleed. And then in fact, one child we had to defer a liver transplant because the child presented with IC bleed, had to be intubated, underwent a surgery. But after that, the child was not able to come out of the ventilation, required a tracheostomy. And then because of the tracheal stenosis, the child got recurrent infection. So liver, we had to forget. And they could never go ahead with the transplant. So it's very, very sad. That's why we don't want to miss. So I didn't want to make it a very detailed talk, but even if this point is taken that we do not miss pale stools and every, not just biliary atresia, even simple things like a neonatal hepatitis can also have vitamin K deficiency and a correctable coagulopathy. So very important to check for INR and give vitamin K.
Point very well taken. And thank you so much for sparing this time. And you said that we can give injectable vitamin K. So can you tell us the dose? Is it 1 mg, 2 mg, 5 mg?
Yeah. So for preterm babies, we give 2.5 mg. Obviously, as I said, slow IV over 10 to 15 minutes. For term babies, we give 5 mg. And once they are above 3 to 4 years, we give 10 mg.
About 3 to 4 years. But of course, that's not the age
That is
when
for
we are.
jaundice. No, that is for other jaundice babies. Any
Yeah.
correct child. For
Yeah.
ALF, basically liver failures and all who present. So to check whether it's a correctable coagulopathy, that is a dose.
Excellent. Also, I wanted to ask you where these stool charts are available, because
Online, ma'am. Online. In fact, I'll be happy to share. I will just share it with you, so you can share it on the Palghar group also.
Yeah. So I don't want you to share just the stool chart, and if you can just share the PDF of your presentation, that will
I've
help
already
us.
shared my PPT, no?
Okay,
With,
okay.
yeah,
With
yeah,
Pallavi. Okay.
yeah.
So can
You'll
we
have-
share that?
Sure.
Yeah.
I'm happy to share, ma'am. This knowledge, as far as it goes, it's good only.
Excellent. Anyone else with any other questions? Dr. Anjali, Hemant, Archana, Vaibhavi, Anuradha, Dr. Bhadbade, Sanjay Wangani,
Alka ma'am is still there.
Alka.
I-
Alka's comments. Yeah, Archana, please go
I
ahead.
just wanted to add during this talk that sometimes the stool color is misleading. So you have to cut the stool and see the
Yes.
color.
Absolutely. True, ma'am.
Yes.
Yeah.
That I wanted.
We had our pediatric surgeon do that for every patient. She used to just see the center of the stool. Very important point, in fact, you brought up. So what happens is sometimes if the babies are very, very ectric, the gut lining itself, the secretions are all yellow. So they might make the periphery of the stool yellow, but the center will be still white.
Yeah.
So that's a very important point that you got. Thank you, madam.
Thank you so much.
Excellent practical point, Archana, and wonderful presentation. Anuradha, any questions? I think Dr. Initu, I don't know who is Dr. Initu, but if he has any questions. Dr. Alka is still there. Alka, any comments?
Yeah, I think Dimple has presented it very well. I was so happy. I've been taking rounds with her regularly. And today I've listened to her after a long time, very well presented.
Thank you,
Actually, what the peripheries of the stool is yellow, whereas center is white. We used to tell our students, we call it as cake taste. You cut the cake.
Cut the cake.
But I mean, I know after this, if you are going to cut the cake, you will remember it always.
Dr. Neetu Mundra, please unmute and give your comments.
I'm actually,
Yeah.
actually traveling, so it will be a bit disturbing. I was saying ki for stool, sometimes it is confusing. You want, just as the ma'am mentioned, ambiguous stool colors. So there are stool cards available very easily, so you can compare, and even your PGs can compare it and comment on it. Which is nowadays we are like recommending to use the stool chart. Don't confuse only. And as the madam said, you have to cut it. So obviously, cut the cake. Yes,
Absolutely. In fact, the use of stool charts is highly recommended. I did not include that study, but I have another presentation where I always include that study, which is only on neonatal cholestasis stool color. So where, in fact, in King's, they have done a study. In London, they did a study in 3 hospitals, and they asked the pediatricians to check for the stool color and comment whether it's pale or pigmented. And to their surprise, they found only 60% were able to identify it right. So 40% of doctors also can make mistake. So we always use stool color chart. It's a routine to ask with the stool color chart only.
Excellent, Dimple. So we have to just show the patient and say which color is the stool.
And this should be a part of the well baby clinic. I think the first vaccination should not go without this.
Yeah.
The sir was trying a lot to include this in the vaccination card itself, but somehow it didn't materialize. But let's see.
Yeah, I think it's a very good thing. So later we can look for milestones, but in the first 60 days, at least ask for stool color.
Stool color, yes.
Yeah,
Absolutely.
yeah. Excellent. So I hope everyone knows that Dr. Neetu Mundra is the neonatologist at Wockhardt Hospital, Meera Road. And she is excellent. And we are planning to do a advanced NRP with her at Wockhardt. So that's about Dr. Neetu Mundra. Thank you so much, Dr. Dimple Jain. It was absolutely a pleasure. And hope to see you more often on our webinars.
Thank you,
and
madam.
Yeah, thank you so much. And with that, Dr. Jagdish, you have anything to add or say or ask?
No, it was by mistake. I got disconnected and again connected again.
Okay. Yeah, so
Yeah.
thank you so
Because I
much
was
for
down
that.
for a couple of minutes.
Yeah. Yeah. With that, we go to the epidemiology of Vasai Virar, because these days we are seeing so many different kinds of infections and problems. So, Vaibhavi, would you like to take this forward now? Vaibhavi? Is Vaibhavi online?
Yeah,
Yeah,
yes,
yeah,
madam.
yeah. I had requested Dr. Kishore Savan sir to come and, sort of give us a quick update on what has been in the past 1 month, but he's busy, I'm sorry, and he cannot attend. So, would you like to take this forward?
Yes, madam. Yes. Good afternoon, everyone. Welcome to our Palghar epidemiology. This is basically brainchild of Dr. Hemant sir and Joshi madam. Basically, we see epidemiology, we see all the cases in different parts of India. We hear in the news, this is there, this is there. But then what actually is happening in our area, we really don't know. Because we are busy in our practice, we don't speak to each other, and we don't know what is going on in the other hospitals and what we are facing and what they are facing. So this is started just to enlighten us what cases we all are seeing in our routine practices. So going forward in last 1 month, whatever measles we are seeing since the last December, January, the measles cases are slowly declining. The measles are more in now in 5 to 6 year old children also we have seen, and the cases are bad, with many of them admitted with LRTIs. But since the cases are decreasing, but still there are many pockets in our area where measles is prevalent. And this is because of the non-immunization of these people. So it is our duty to make sure that everyone gets immunized, to hamper immunization on each and every individual that comes to us. And our Anganwadi workers and Asha workers are doing a lot of work in these remote areas, but still we also have to do the things. Going forward, then we have acute tonsillitis. In nowadays, in all 5-6 years, and in the older age group, we are seeing very big tonsils with high CRPs. CRPs going up to 110, 112, and these kids are also taking a long time to recover. Usually responding to augmentin, but that also after 7 to 8 days of treatment. The youngest child that we have seen with tonsillitis is a 6-month-old child. So indeed, tonsillitis is prevalent in the OPD practice. And other things in OPD practice are our usual LRTIs, a cough, cold, fever, viral URTIs are very rampant. All the kids have started going to school and passing on the URTIs to each other, and recurrent URTIs are many common. In IPD, we are seeing many LRTIs, lower respiratory infections, with big patches in different multiple lobes. These are also taking a long time to recover. Say even after admission, they are taking 5 to 6 days, and with high ESRs, with high CRPs, slowly coming down. And then comes the bronchiolitis. The bronchiolitis is really causing sleepless nights because of the respiratory rate, what they are bringing around, say, 80, 90, requiring high oxygen and nasal O2, and they are most of them on or air O2s because of the high respiratory rate. They are also having high CRPs and all. Since we are seeing so much lot of bronchiolitis and LRTIs, what we have done, we have started with respiratory biofire. This is usually, we take a swab, and we take a nasal swab and a throat swab, and we send it to the laboratory, and we get the report in around 24 to 36 hours. With this respiratory biofire, we have identified one case of adenovirus, which was really very bad. The child was in our hospital for, say, around 7 to 8 days, not responding to any of the treatment. and his respiratory rate was continuously increasing. We had to transfer the patient to the higher institution, and unfortunately the child succumbed and he had adenovirus. So with the help of this biofiger, we could identify adenovirus. We have another child in our ward now, whose biofire we had said, and it has come as influenza A positive. So I think in all the LRTIs and in this bronchiolitis, it is better to do now. Since we are knowing it, it is good to do this respiratory biofire. It cost around 8,000 rupees. And yeah, it's a little high, but if we tell them negotiate, they come down to 6,000 rupees for not so affording patients. And because this viral bronchiolitis and these viral pneumonias are taking a lot of time to recover, usually in 3 to 4 days they used to recover, but in this season they are taking a lot of time, and it is very counseling part becomes difficult in counseling the patient why it is not yet recovering. So if you have this in mind, we can say such and such thing is there. So it will take time to recover. Second, nowadays, at least in the past 1 month, hardly we have seen a case of malaria, no case of dengue, no case of typhoid. All this has gone down, and only respiratory cases are being seen. That's all from my part. Yeah.
Archana, you'd like to say something? Dr. Anjali, you want to add? Anuradha wants to add?
Hemant.
Yeah, Hemant. Yeah, Hemant.
Yeah, Miss Anko.
Camera.
Just a minute. Yeah. Number one, you all should see, if you can, the Shark Tank program on Sony Live. Sony Live is a phone app, OTT, or wherever you see. So in that, one Malad industrialist, he presented a fireball. They call it auto fireball. You know, the ball with the heat, it explodes and then it finishes the fire, extinguishes the fire. So you can, suppose there is fire and you can't do anything, just put it there, it extinguishes fire and you can run up. So I asked my fire officer, he said, Western balls are very expensive and Chinese balls have failed the test. So we don't recommend both. But this person is from Malad, he has got many awards. The ball costs 5,000 rupees, but we bought a dozen today. So we got it at the rate of 2,500 plus GST. So you should have it in kitchen or where the the electricity board is in each house and in our hospitals. That's it. If I can show you, I'll show you the ball.
We can see the ball
We
here.
can see it.
Yeah, there it is.
Yeah.
Yeah.
Thank you.
It's made in Malad, made in India. There's many awards and it works. So let's be safe than sorry. Thank you.
Thank you so much,
Hemant.
Hemant.
I'll put the details on the
Yeah, please do that. We also have all these because it's become compulsory by the fire department.
And I know, this is made in India and it works. And it's,
Yeah.
I don't know the cost, but it is cheaper than the Western ones and dependent.
Yeah, thank you so much, Hemant, for sharing that.
It has 5-year expiry. So, and it will work forever. Thank you.
Great. Yeah.
I have a question.
Yeah, Neetu.
So how do we collect this epidemiology data of Palghar? Like you have some case reporting form, any cases doing, just out of curiosity, I'm just asking.
Yeah, we have a WhatsApp group, Neetu, and the WHO officials as well as the other VVCMC officials in charge of collecting data, surveillance data for AFP, measles, tuberculosis is on that group. Diphtheria, tetanus, all the notifiable diseases. So basically all the vaccine preventable illnesses which the municipality is, VVCMC, the municipal corporation is giving, is included in the surveillance. And we have to report on that group.
That data you are using, like Madam mentioned about tonsillitis also, which is not...
No. So, no, this is her own hospital data. She's sharing data of her hospital.
Okay.
Madam, basically this epidemiology started so that people from all our Palghar area, that is Palghar area extends from Vasai to Danu Boisar, so everyone can share whatever they are seeing. Like I said, in our busy schedule, we don't meet each other, so we don't know what you are doing, what is new, what you have learned from your practices.
Yes,
Means
yes.
it is always a trial and error in our practice. So like everyone discusses what they have seen in the last 1 month and what they have tried and what is the newer treatment, or what, if like referring, what we come to know. It is basically that.
Neetu, she is only presenting data from her hospital and she's inviting everyone to present their data. So I will be sharing some of my experiences. So I don't have any data written down. I'm not done any biofire, but I'm very happy Vaibhavi has done. And if she has done any more, then if she can give us details.
No, I can show you the biofire, this thing. This is the swab. I'm not open.
No, it's a nasopharyngeal swab. We don't want that. I just want your data. So if you have any data.
We have just started it. So I think by next month we can collect the data.
Yeah, sure. That'll be lovely. And we haven't done any, but I want to share one case with, when you said tonsillitis, we had one very obese 12-year-old boy who was 74 kgs and who had, his sister had cough, cold and fever and she recovered. But this child got admitted with 104, 105 fever. And for 4 days, he was very sick. And along with nasal congestion, mouth breathing, throat, he also had severe abdominal pain, loose motions, vomiting, so much of nausea that for 4 days he hadn't eaten anything. So just wanted to share, and we didn't do any swab. His CRP was very high. And we had initially started him because of his severe abdominal pain, vomiting, and loose motions. We had started him on ceftriaxone, but he didn't respond. And then we gave him azithromycin because he wasn't taking anything orally. We had to start on syrup, although for a 74 kg, it was a very large dose. And glad to say that he responded. He didn't have any patches on throat, and I was reminded of that standard treatment guidelines which this one had shared, Dr. Deepak Sonawne, and he had shared that if you see, petechiae and strawberry tongue and breathing, which is, nasopharyngeal congestion, then one must suspect group A streptococcus, and that was what we had seen. Also, a lot of children with viral infection with very severe nasal congestion. So it is like a nasopharyngeal infection rather than just pharyngeal infection. So we are seeing lot of adenoiditis as well, and lot of children who get chronic adenoiditis have come with severe mouth breathing, snoring, and even sleep apnea. So this is what we are seeing. Lots of children with very resistant coughs. So cough, which is so difficult to treat and so difficult to control. So we are also getting lots of these children. And so many of the children who have had asthma in the past are coughing incessantly, and we had to restart them on their budesonide and salbutamol inhalers. So this was some of the things that we have been seeing. Even very small infants with very, very severe coughs. I don't know whether you all have grown RSV on any of your cultures, on your PCR.
No, not yet.
No. So I've not done biofire, but I think it would be a good test to do. And especially those who are hospitalized and are getting reimbursed might be well worth the test. So that is, Anuradha, you wanted to share something? Anuradha, I think she's lost connectivity for some time. Archana would like to share some data from her. Archana, you'd like to share some data?
No, Anjali, nothing much. I share the same experience of RSV viruses, lot of respiratory problems and coughing, and less of diarrheas and pneumonia, other illnesses, typhoid, malaria. Okay, we are seeing the same things. Okay,
Yeah.
Nothing more.
Yeah. Anyone wants to add something? Jagdish, you'd like to add something from your side? Vaibhavi, Anuradha, you're there. Would you like to add something?
Yeah, we are also seeing same respiratory cases a lot. Initially, we saw few cases of dengue, but nowadays, since 2-3 weeks, we are seeing lot of tonsillitis, URTIs, and recurrent URTIs common. Difficult to counsel parents, definitely, and LRTIs. And as you said, tonsillitis with loose motions, usually I have seen that they respond to oral azithromycin, and we have treated lot of such patients in on OPD basis also. And one patient required piperacillin tazobactam for tonsillitis because that child did not responded to augmentin after 4 days. So we shifted, and child was very toxic with high grade fever, and then we shifted to piperacillin tazobactam, and then that child responded within 48 hours. And others are well responding to amoxicillin clavules. That's it. But yeah, on OPD basis, to avoid admissions for tonsillitis, if I add azithromycin on day 4 after amoxiclav, they are responding. So I have to add this time I have to add a second antibiotic for tonsillitis to avoid admissions. So that is what I am following for tonsillitis.
Yeah, Archana.
Yeah, are we doing throat swab cultures for these recurrent tonsillitis and with large tonsils? I think that would help us to select the right antibiotic.
But I think it takes time. Sometimes because of high fever, parents get very apprehensive, and they say that you admit the child, better you admit the child because of the high grade fever and toxicity.
There is one Dr. Prasida from Mopkar lab. She rings you and tells you the report instantly. So that gram stain and culture will take some time, but she can at least tell you, let's say, the gram positive bacteria in chains or in clusters, so that we can at least select the right antibiotic. We also use
a lot of dysentery also,
yeah.
Which anybody has not mentioned. We are seeing a lot of dysentery patients. They are not responding to cefixime, and sometimes they need admission. They are responding to ceftriaxone, and sometimes we have to add azithromycin.
Two things I'd like to say is that I've changed my practice from giving co-amoxiclav for a little older children to giving only amoxicillin, and that has I was initially a little resistant, but I have seen a good response even with just plain amoxicillin. Happy to share that. Also, I wanted to say that I have been very resistant and very reticent in using azithromycin because last year Dr. Upendra Kinjwadekar had addressed us, and he had said that it is a reserved drug for resistant tuberculosis, and I use clarithromycin instead of using azithromycin, and it was only in this patient because so I think a lot before giving azithromycin. I feel very guilty, and like Dr. Amdekar says that your hand should shake when you write this. So yeah, so I do it with a shaky hand when I write azithromycin, because when we write, there will be 30 other people who see us and do the same. So I have been a little hesitant to give
Tanu Singh
azithromycin.
madam told us about azithromycin, role of azithromycin in dysentery. If they are getting persistently high grade fever after 4-5 days also. So we have rampant dysentery over here, and we are getting a lot of patients.
You're seeing a lot of pus cells in the stools?
Yes, madam. Yes, 30, 40, 50, 60 to 70 pus cells with RBCs and toxic child, green stool, blood in stool.
Okay.
Yeah.
Anjali,
No,
also use a lot of penicillins.
okay.
You only introduced that to us, and we are using a lot of penicillins, and we are getting
Oral penicillin, pented. It's little difficult.
and injectables.
Okay.
So
For
getting
dysentery. No.
No. That she's talking about
Respiratory
for. Yeah. So with this, can we go to the last presentation for today? And that is standard treatment guideline. I chose to present sickle cell anemia because we are looking after a lot of sickle children in Dahanu. And this Saturday, I could not go on the 21st, but I'm sure next month I will be going. And since IAP Palghar is looking after so many sickle children, I thought that we should have the standard treatment guideline. Now, I hope my presentation comes on the iPhone, iPad. I don't know whether. So, Pallavi, can you help me? I have my presentation here. I don't know whether anyone can see it. No, I don't have it here also. Yeah.
No, ma'am, we cannot see your presentation, but try again. Just open the presentation.
Oh, no, I can't see it also.
Is it open?
I had opened it before. Now I have to go to WhatsApp and see. Just a minute.
No problem. Just open the presentation.
1 minute. But I'm not sharing it. Palghar Academy of Pediatrics. Yes, I have shared it. Yeah. So now, shall I open it?
Yeah, just share the presentation, ma'am, first.
Share with?
Share screen. Just click on the share screen button.
Okay. 1 minute. Now, let me minimize this. Share screen. Okay.
Yeah. Now you will get the windows. Click on your presentation window.
Can you see it?
Yes, ma'am. It is coming.
Yeah,
Yes.
but I don't know how to make this full screen because this is.
No, it's a PDF. It will show like this only. Just click on the plus button. It will make it enlarged. That's it.
Okay. So
the plus button, 100%. Near 100%. Yeah. It will get, that much.
Is it better?
Yes, ma'am. Definitely.
Okay. Practicing pearls in sickle cell disease management. This is one of the standard treatment guidelines which was presented by the IAP. And Dr. Ramesh Kumar, Upendra Kinjwadekar, Dr. Piyush Gupta, Vinit Saxena have been the masterminds behind all this. And this is for practical. I have to make it small because I myself can't see it very well. So how can I remove this? Yeah. Okay. Yeah. Sickle cell disease is an autosomal recessive group of disorders, and it is caused by a qualitative mutation in the genes, which encode for beta globin chains of the adult hemoglobin. And this abnormal hemoglobin is known as sickle hemoglobin. And on deoxygenation, it forms a polymeric structure which results in deformed rigid red blood cells, leading to chronic hemolytic anemia and vasoocclusion. It encompasses, so there are many kinds of sickle disease. One is sickle cell anemia, which is the most severe, called SS, that is homozygous. Then there is sickle cell hemoglobin C. It's a combination of hemoglobin C and sickle cell. There is sickle cell beta thal, that is S beta thal, and other compound heterozygous conditions such as sickle D Punjab, sickle E thal, and sickle alpha thal. And I'm very sad to say that we see almost all of this at Dahanu. So we are seeing so many combinations. And the epidemiology, there is a sickle belt of India which spans across. So it's called the coal belt of India. And it passes through our Jawhar, Mokhada, and Dahanu, Boisar area. There are a lot of these children. Most of them go for diagnosis and treatment to Surat, which is very close by, which is so sad. So we in Maharashtra are unable to do much for them. And the tribal areas, just look at the incidence. The incidence ranges up to 40%. So I was amazed to know that from one school, they had 80 children who had the sickle trait. So that is the amount of, and the tribal population has a lot of marriages, marriages amongst themselves. So getting a sickle cell child is so very possible. How does one diagnose with newborn screening? Which HPLC? So there are many kinds of hemoglobin electrophoresis. There is a gel electrophoresis, and there are other screening tests, but doing an HPLC or a high performance liquid chromatography is the way to diagnose sickle cell disease. And this is done in a child with chronic hemolysis, pain, crisis, and of course, to do a genetic mutation analysis in those whom we suspect this, because we can come to a correct diagnosis in such children. Now, I wanted to say how important this diagnosis is. 2 days ago, I saw a child who looked pale, and the mother also looked very pale. And I said, you look pale. Are you the child was just 6 months old. I said, are you taking iron? And this saying, I was transfused twice in pregnancy. I said, this is too bad. So what do you have? And she very coolly told me that I have sickle cell disease. So I think it's very important to know about sickle cell in our mothers as well. So how do we suspect? So if any mother has undergone a transfusion or has for severe non-responding anemia, has had a testing done further, we must ask them if HB electrophoresis are done. A lot of mothers do come forth. After that, I asked another mother, and she told me I'm a thal trait. So I think there are a lot of mothers who are now aware. There are a lot of obstetricians who do HB electrophoresis for their patients who have resistant anemia. So do ask for this history, because doing an HB electrophoresis in all our children who have anemia, I think, is very important. What are the symptoms and pathophysiology that we can see? And most of these have been seen in almost all the patients who come to the HANU. So there can be stroke, there can be retinopathy, there can be acute chest syndrome, there can be renal infarcts and papillary necrosis, there can be otosclenectomy, aseptic bone necrosis, osteomyelitis, leg ulcers, dactylitis, congestive cardiac failure, jaundice, chronic hemolytic anemia, pigment stones, and of course, there can be crises like sickling crisis, hemolytic crisis, aplastic crisis, and sequestration crisis. I wanted to highlight some of the patients that I have seen in Dahanu. One child came with, an ulcer on the medial side of the leg, and this child had sickle cell anemia. When I was doing my during my postgraduate days, I had seen one child who came with septicemia and osteomyelitis, and when we did the blood culture, it showed Salmonella typhi, and the registrar at that time said this is sickle cell anemia, because no one gets S. typhi osteomyelitis, and sickle cell children do get, and it turned out to be sickle cell anemia. I have a nurse who is working with us and who had worked with us initially 10 years ago, who used to get very severe acute chest syndrome. She used to get severe breathlessness, and she used to get pain in all her limbs. And this girl was a sickle cell. At that time, she used to be repeatedly transfused by the adult physician. And fortunately for us, we had a hematologist visiting us, and she started her on hydroxyurea. And since then, she has been symptom free. So just to tell you that almost all of these symptoms can be seen in our patients, and we must be aware of them. What are the tests, list of investigations that we need to do before we go for treatment is, of course, a CBC, a blood grouping, because at any time these children may need a blood transfusion, and HB electrophoresis by the HPLC method of the patient and the extended family. I'm happy to say that at Dahanu, there is a lab called a Mahalab, which is run by the Maharashtra state, and they do free CBC, and they do a free HPLC, which is so good because we send the patient as well as his family and all of them get their HPLC done. And also, there is the ICMR, which is working, and they do for all the inborn patients at the Hanu Sub-District Hospital. So they have their own testing as well as follow-up, as well as now that Dr. Amit Jain is visiting there, he's looking after the newly diagnosed patients who are older and not the newborns. And HIV is needed, a renal function test, liver function test, and a G6PD test is also needed in most of these patients. And all these tests are done free of cost, at the sub-district hospital. That is done by the Hanu sub-district hospital, whereas HPLC is done by Mahalab, the state lab. How does one manage? Sickle cell disease should be considered a chronic, long-term and a life-limiting condition with acute exacerbations that have far-reaching disabling consequences. And they need lot of, so most of these families are unaware of what needs to be done. Most of us pediatricians are also quite unaware of all these things, and it's only if we keep sitting with a hematologist that we will know. But of course, we form a part of the team. So a pediatrician, hematologist, and immunohematologist, and intensivist, psychologists, social workers are all needed. At the Hanu right now, we have pediatricians and hematologists, and we have some social workers who also are available over there, but the rest of them are not. We hope that we can. And for immunohematology, we refer them to KEM Hospital, where the immunohematology lab is run, and even the tests there are conducted free of cost. The non-pharmacological methods, of course, is parent education, and very important to tell them to maintain hydration. We have one of the social workers there who tells every patient to drink a lot of water, and to avoid extreme cold, heat exposure, heavy exercises. Diet, which is of course a well-balanced diet and rich in vitamin A and zinc, has been advised, and no role of vitamin C and E in the management, or even soda bicarb. I remember doctor from Nagpur, he always says bicarb la soda. So that's one of the things for sickle cell as well. Immunization in
that is Dr. Satish Dev Pujari.
Satish Dev Pujari. Yes, he always says that bicarb la soda. And immunization in sickle cell, apart from all the routinely recommended vaccines, children with sickle cell must be administered pneumococcal, Haemophilus influenza B, meningococcal and typhoid vaccines as per the IAP guidelines. Now, influenza B is given, and all children born after October 2021 have received the pneumococcal vaccine. At the Hanu, we are giving pneumococcal vaccine to those who have not received it earlier. That is done by the sub-district hospital. And there is an NGO which is very kindly giving us typhoid vaccines. So far we have vaccinated more than 50 children with typhoid. We are also looking forward to giving them the meningococcal vaccine as well. So these are some of the things that we are doing at the Hanu, which is there in the recommendation. Antibiotic prophylaxis, oral penicillin V, like Archana just mentioned that they are using it for respiratory infections. We have to continue prophylactic penicillin beyond 5 years of age if the child has undergone a splenectomy or had an invasive pneumococcal disease. But these days, because pneumococcal vaccine has been started for these children, and also we are giving the typhoid vaccine, this is not recommended. But those who have not received either of the pneumococcal vaccine should be on prophylaxis, and here the doses are given. I want to also inform that this standard treatment guideline is freely available on the IAP site. And if you just type IAP standard treatment guideline sickle cell, you will get this recommendation. I'm also going to share this PDF with everyone. I think I've already shared it on the group. And what is the role of hydroxyurea? Hydroxyurea is known to increase the fetal hemoglobin and it reduces the incidence of acute painful episodes and hospitalization rates, and it prolongs survival. This I have shared with you that the nurse who works with us has had a first-hand experience of this, and she shares this with every patient who comes over there and tells them to continue taking. And I wanted to share this story at the Hanu. There's one girl who travels very far and has to spend 500 rupees to come to our place. And we were just talking with her, and we said that she's 12 years of age and she doesn't go to school. So we asked her father why. He said that it's only 6 months ago that I started hydroxyurea, and now my daughter can move about. But before this, she could not walk, she could not get up from bed because she had such severe pain. So hydroxy, and it's really painful. And to know that this girl didn't go to school at all, and she's 12 years old, and she could not go only because there was no hydroxyurea available to her and nobody was there to guide her, and she could not go to school. But now he knows the importance, and he spent 500 rupees to come from that remote village. He says, I have to start at 5 a.m. in the morning to reach her at 9 a.m. But I come because now my daughter can move about. So that is the difference hydroxyurea makes to pain in children with sickle cell disease. And what are the doses? We begin in a very small dose. The doses are given here. I don't think it's very important for us to know the dose. It's enough for us to know that hydroxyurea can be given. Unfortunately, it's not available as a syrup, and the tablet available is 500 milligrams. So sometimes the child has to break it and they have to take it once or twice a week just so that their weekly requirement is met. But I hope someday will come when 250 milligram tablets or a syrup will be available. It has to be very well managed. It started after the age of 9 months of age, and to anyone who is having sickle cell disease and has a low hemoglobin and also has any other symptoms, and it needs regular follow-up because it can cause bone marrow depression as well as liver and renal side effects. So once the child is on hydroxyurea, every quarterly we do a CBC retic count. We don't do a retic count there, but we do a CBC renal function and liver function test. And all these children are given folic acid 1 to 5 milligrams per day. And that is because all of them have a very high erythropoiesis, and folic acid is used up to a great extent, and we have to replace it. What are the indications of blood transfusion? Only if there is very severe disease which has a clinical stroke or has acute symptomatic anemia, has a parvovirus 19 infection, or has a splenic sequestration, or has an acute chest syndrome. So like I shared, our sister hospital nurse used to get very frequent transfusions because she used to get severe chest pain. And after starting hydroxyurea, she has never been transfused even once, and her pain has all gone away. So that is the extent to which we can help these children, and also blood transfusions can be prevented. So any child who needs very repeated blood transfusion, we must see that whether they are getting, hypersplenism and splenic sequestration. So in splenic sequestration, there was one girl who used to get, the mother very classically said that she gets a very big swelling in the left side of her abdomen, and then she needs a blood. And that was a child which Dr. Amit Jain then referred to CTC at Borivali and said that this child will need a splenectomy. Of course, they have to all be looked for iron overload, especially those who are undergoing transfusion frequently. Not everyone needs blood transfusions. If they are well managed from the beginning, then they don't need blood transfusion and they don't go into iron overload. But otherwise, the recommendation is the same as for thalassemia. So if they have had more than 10 to 12 transfusions, or the serum ferritin is more than 1,000 micrograms, or the liver concentration is more than 7 milligram per kg, then they will need, and the medicines are the same, desferrioxime or deferricerox. So these are the medicines that can be given. And management of acute complications are, of course, acute febrile illness. So anyone who has a fever will get an antibiotic, may need admission. If the child is toxic, will get IV antibiotic, and will be then worked up for the cause of infection. Generally, ceftriaxone is started in them. A blood culture is also sent. And these are all the things that you can do. There is a box that is being given. But mainly, we have to learn to manage pain, because pain is one of the commonest symptoms that they come with. And the medicine that can be used often are paracetamol, ibuprofen, codeine, tramadol, morphine, and ketamine. But paracetamol is one thing that is freely available to them, and we can give them paracetamol and oral dose. Often it is difficult when they have joint pains to know whether they have bone pain, whether it is just an infarct in the bone or an infection. And there is a whole protocol which Dr. Amit always explains to the residents over there, that first you start on paracetamol, see the response to pain, and then we can think of infection. So this is what they do, but they start antibiotics very early in such children, and then sort of follow up the child to know whether it was just an infarct or whether it was osteomyelitis. That was about an acute febrile illness, bone pains, how to manage stroke. If there is a stroke, then of course maintaining hydration and doing an exchange transfusion to reduce the hemoglobin S to less than 30% of total hemoglobin. Acute chest syndrome will need effective pain control, oxygenation, empiric antibiotics, and blood transfusion. I've not seen an exchange transfusion done for an acute chest syndrome. Acute anemia, there is a flow chart, what is to be done, and that is related. So acute anemia can be because of three main reasons. One is splenic sequestration. The second is whether it's an aplastic crisis, or third, whether it's a hyperhemolytic crisis. And there is an algorithm for it, a flow chart, which we can see and follow up. But all these patients, we have to be aware of what can cause that severe anemia, and of course, refer to the appropriate person. The only curative treatment is hematopoietic stem cell transplant, but this is not indicated for everyone, unlike thalassemia. So thalassemia, almost everybody is recommended for a hematopoietic stem cell transplant, but in sickle cell, only those who are very severely ill and get very frequent infections, or have splenectomy, or have suffered from a stroke, they will need. So the need for hematopoietic stem cell transplant is very selective, and only very few patients will need that. But all of them need regular growth monitoring, monitoring of their nutrition, management of pain. So almost everyone goes home with a paracetamol strip, because that is something they may need on a very regular basis, and they do use it. How does one manage? So every 3 months, one has to do CBC, RFT, and LFT. A transcranial Doppler is needed annually after the age of 2 years. We have not been able to manage because this is a little expensive investigation. It costs about 3,000 rupees per child. And at CTC Borivali, they have donors, but we have not managed to do that at the Hanu as yet. Oxygen saturations, BP, and pulmonary function, 2D echo is only needed for those who have very low saturations and get repeated chest syndrome. And everyone needs to get a urine analysis after 3 to 5 years. If they are receiving blood very often, they will need HB, all the triple H for that. And they will, like for thalassemia, they will need an MRI of the heart and liver, ferritin. They may need a retinal screening and MRI if there is pain in any of their joints or bones. Psychological, educational, and social interventions is something that is very essential, but very difficult to get by, because difficult to get psychologists and social workers So Dr. Mamta Manglani has been trying very hard to get a psychologist and a social worker to work over there. What is the role of prenatal testing in sickle cell? Because the disease can be prevented. But very sad to say that so many of the couples over there, in spite of knowing that both of them have trait and have one children with disease, still go ahead for the second one without prenatal diagnosis. Because for them to travel all the way to Borivali, where it is done, prenatal diagnosis is done free of cost, also means missing a day of work and means spending some money, so they don't go for it. That was the sad part. And indications of tertiary care referral, of course, and any acute and complicated sickle crisis, and anyone who needs multidisciplinary care, anyone who needs genetic counseling, and during pregnancy. What are the future and what are the newer things that are coming up is a monoclonal antibody which prevents vaso-occlusive crisis is crizanlizumab. And there is one more which prevents hemoglobin S polymerization is voxelotor, but I'm not sure about this. I had hoped that Dr. Amit Jain would be on this talk so he could expand on this. I'm not an expert and I won't know much about this. And of course, there is gene therapy. So with this, I have finished presenting sickle cell disease and all my experience, my very limited experience about sickle cell disease and our role as IIT Palghar in Dahanu Sub-District Hospital with sickle cell. That's all for my presentation. If anyone has to add something, Dr. Jagdish Bhadbade is also very much in Dahanu, and he can also add to whatever I have said.
Just 3 comments I would like to make.
Yeah, Jagdish.
Since it is very much prevalent over here, we are lucky that most of the Anganwadi, when they are registered antenatally, mothers are registered there, many of them are subjected to electrophoresis, and most of these women after delivery, when they come to me, they carry their card and I get the report of hemoglobin electrophoresis, whether it's sickle is positive or negative with that mother. So if she is positive, immediate neonatal screening of the baby. In fact, all the babies we recommend neonatal screening for sickle soon after birth. Second comment is, when you said autosplenectomy, somehow in our population, our phenotypes, autosplenectomy is not seen. In fact, what we see is a massive splenomegaly with recurrent sequestration, recurrent hemolysis going to the extent of hypersplenism, as you had said. And third one, which a comment which might evoke some controversy. When you say iron overload, I understand when the child is being transfused repeatedly, but not all sickles need repeated transfusions. Most of these sickle cell patients in their infancy come with painful crisis and food syndromes. And my observation is, just as any child from these low socioeconomic strata, tribals, most of iron deficiency anemia, we know very well that it's very common among these children. So just as any common child will have iron deficiency anemia, even these sickle cell anemia patients do have iron deficiency. And my observation over the years is, if you do iron studies in them, and if iron deficiency is found, and if you correct that iron deficiency, the frequency of painful crisis goes down. So now we have started a study in our college. In fact, one of my students has taken up this topic to find out iron deficiency in sickle cell patients who are not requiring frequent transfusions and the effect of correction of iron deficiency in the children on the symptomatology. So when we talk of iron overload, we also have to think of iron deficiency in the children and correct that by doing iron studies. And we should be aware of this aspect of sickle cell disease or sickle cell anemia also.
Absolutely true, Jagdish, because some of them do have, just like thalassemia trait can have iron deficiency. Most of our sickle cell children are pale because of
correct iron deficiency anemia, and their painful crisis will go down.
Yeah.
And for the painful crisis, Amit always says better is to give ibuprofen because of its anti-inflammatory effect than paracetamol.
Yeah. Unfortunately, at sub-district, ibuprofen is not available.
It's not available.
Yeah,
It's not
so we
available.
give paracetamol.
Correct. That's a compromise we have to come to. Yes.
Yeah. Yeah, Hemant.
What about fetal testing? Korea.
So they're doing Korean villi biopsy at CTC in Borivali. It's done free of cost. Any patient can go over there, register and get it done. All pregnant ladies who have had sickle trait and have had a previous child with this can go there.
Where?
Borivali, CTC.
CTC
Thalassemia Center. Dr. Mamta Manglani and her group is working there. CTC Borivali. It's done free of cost.
Good.
And another complication with children when they grow older, I have seen those infants with sickle cell crisis, whom we have followed over the years, when they go up to the age of 18, 19, and still they come to me, is avascular necrosis of the femoral head. I have seen a lot of children with avascular necrosis of femoral head.
Yes, Jagdish. All these inputs are very important, and I think a prophylactic MRI, if they are getting repeated pain, would really help them and prevent this complication.
One child.
How to treat ATN in avascular necrosis femur?
How to treat? I didn't understand.
Avascular necrosis. Avascular necrosis of femur, they get severe pain and it is irreversible actually.
Yes. They will need a implant to be put. Implant. That's an orthopedician's purview, and we have to diagnose it with MRI and refer the child.
A baby would come to us, a small tiny baby would come to us till he was small. As he became adult, he went to adult physician, but he died at 20 years in a crisis.
Yeah. So many of these patients, adult physicians may not be, like nephrotic syndrome should be followed up. Even some of the juvenile rheumatoid arthritis should be followed up by pediatricians, even if they become adult. Sickle cell is also one such condition which adult hematologists or adult physicians may not know. So also should go to a pediatric hematologist. So pediatric nephrotic syndrome, going into adult, rheumatology, going into juvenile rheumatoid arthritis, going into adulthood, and sickle cell disease and thalassemia are so well managed by pediatric subspecialties.
I admire you all. I admire you all for your free monthly service at Dano Center.
You all know, it is us all.
I know, but you all actually go. We only are.
That's okay. But it is our project. It is not any individual. It is, and we have to appreciate Dr. Mamta Manglani and the people who come, because every time there are at least 2 or 3 pediatric hematologists who come. Dr. Amit Jain himself comes, and this time he brought 1, but he said if they had let me know that 1. So I want to tell you that 120 children were screened and tested this time. So 120 children were examined. So he said that if I had known earlier, then I would have got 2 other fellows. So they bring pediatric hematologist fellows with them. And we are giving them vaccination. We have been able to give them pneumococcal vaccine, and we have been able to give them typhoid vaccine. So this is something which is very heartening. But there are still a lot of work to be done. We have to have regular growth monitoring. But there's so much to be done that we need lots of people. Yes, Hemant.
See, what you are doing is curative. Fantastic. We are proud of you, right?
No, not curative. It is not curative.
Controlling.
You help.
Counseling.
सेवा चांगली करतात. मला इंग्रजी नाही.
Yeah.
If you take a camera, a mobile camera stand and video your communications and take out pieces and use them for educating masses, you'll have a big footprint like a Vaman covering the whole earth one day.
Okay, thank you. We'll do that. So there are many videos. There is I forget the name offhand, but there is a sickle cell group, and they have made many videos, and we share. We have a sickle Danu group, and we share it on that. They have educational leaflets in Marathi as well.
Good. May your footprint grow from Danu to Assam.
Thank you. Yeah. So I think we are nearing the end of our program. Vaibhavi, तुला काय म्हणायचंय? Anuradha, Jagdish, anything more?
No, nothing more. Nothing more. Thank you.
Very happy you could join in today. Anuradha?
Yeah, I could join luckily today. Early.
So nice, thank you.
एक फिजिकल मीटिंग जगदीशच्या मळ्यामध्ये घेऊ तर आपल्याला तिळगुळ मार्च मध्ये पण मिळेल.
नुसतं तोंडाने गप्पा मारतो इथे येऊन जातो भेटत नाहीस मला.
Okay, so with that we have come.
You are always welcome, but you are always welcome. You are always welcome.
So we have come to the end of today's event, and I thank everyone who were present. I am thankful to our presenters, Dr. Anjali Muzumdar, who is a pediatrician at Joshi Children's Hospital. I thank Dr. Dimple Jain, who is an expert in herself. I thank Dr. Amit Vatkar for joining us. He is a pediatric neurologist. I thank Dimple, who is a pediatric gastroenterologist. Alka Jadhav ma'am, who joined us all the way from her residence at Dadar. I thank Dr. Hemant Joshi, Archana Joshi. Yeah, Hemant, you want to say something?
I want to tell you something. Next time you get a child with sleep complaints or snoring or whatever, or day somnolence, ask them to just put on their mobile, put a small light and then video the child's sleep. This is such a nice study. It just changes your treatment. Because seeing is knowing the problem. Is it snoring? Is there sleep apnea? Or whatever. So do try. It doesn't cost anything. You just keep a light on and put the mobile on with the charger connected, because otherwise the power will be consumed.
Discharged.
And enough memory inside. Thank you. I've done that, so I'm telling you.
Thank you, Hemant. So thanks to Vaibhavi for the epidemiology inputs, and hopefully next time we'll have more this about the biofire. And Dr. Hemant Joshi is going to share with us the this of that fireball. And so with that, we come to an end, and we look forward to, I'll be sharing the 28th January free OAE and BERA testing flyer poster with you all. So please do refer patients who would like to undergo BERA testing, especially those small NICU patients who cannot afford to get a BERA done. And with that, I thank everyone who is present on the webinar today. And we will meet on the 4th Wednesday of next month. And hopefully Dr. Anjali will come another that time as well.
Ma'am, 4th Wednesday will be the Pedicon week. So,
so the week after.
Anjali, we can make our footprint bigger.
Yeah.
The lady who does that our work just now, Ashiki बाई करते हैं ना ते आपला पल्लवी करते कि नहीं करते आपला
पल्लवी करती है.
Pallavi has database of entire Maharashtra and the country. It takes some 30 paisa for one SMS message or WhatsApp or email. She can reach our CME message to all the 5,000 pediatricians of Maharashtra or 32,000 pediatricians of the country. Those in remote places,